the dysfunctional liver in the ICU over the last couple of years, we've really started to think more closely. As you know, I know for all of you that you're looking at, kidney function. We're paying more close detail. We're looking at acute kidney injury. I think that with liver, we also need to pay closer attention. Remember, most of the metabolism of most of the drugs that we use, not necessarily the elimination. Now, the kidney does the elimination, but the metabolism of our drugs is done at the level of the liver. And in fact, if you're thinking about, let's say, you've got a patient with a cardiac stent, okay, and they're on antiplatelet drug, like clopidogrel. Now, remember, clopidogrel is processed in the liver so that it can be functional. So there are lots of drugs that we use on a routine basis that are made functional by the liver. So in the absence of good liver function, now remember, we lean on the fact that, most liver function is about, we use about 20% of the functional liver, right? I mean, the remainder is excess, if you will. So something to think about as we're thinking about, acute on chronic liver failure. Now, these patients do fairly well. I mean, even the alcoholics you see that have cirrhosis, they do fairly well until they're tipped over by something. And that's why I always tell people, if you got a patient with a variceal bleed or something, the question that you have to keep asking is what tipped them over? What was the tipping point? Was it an infection? Usually that's what it is. Or did they suffer some form of a stress that caused them to start bleeding? Once the bleeding starts, then that cycles on itself. So really speaking, this is something we have to think about. You got a 45-year-old male, history of alcohol abuse, presents to your emergency room with shortness of breath, is intubated, subsequently transferred to the ICU. Now, what are your priorities in management, and what do you need to address? And these are things that, I want you guys to really kind of focus in on when you're going through your assessment of these patients. Take into account the fact that they have a history of cirrhosis or a history of chronic liver disease. So then put in the fact that you have an acute process on top of that. Think about the acute process that you're dealing with. So acute on chronic is a clinical syndrome, obviously. Acutely decompensated, acute liver decompensation is something we see that can be managed by specialists, that can be managed on the ward. They have a little bit of variceal bleeding, but it's not terribly bad. The patient is not really septic. The patient is not having severe inflammation throughout their body. Now, that once you get into the systemic inflammatory response issue on top of what you're dealing with as far as liver, then that's what we call acute on chronic liver failure. That requires us to pay a lot more attention, and those patients are going to be what we're going to see in the ICU. So this talk is going to deal with that acute on chronic liver failure. You're dealing with systemic inflammation. You're going to have to be attentive to the degree of detail that's needed to manage these patients, and we're going to talk about that. Acute decompensation, again, medical specialist in the ward, okay, they may have a little bit of ascites, they may have a little bit of hepatic encephalopathy, and again, plus or minus gastrointestinal hemorrhage, plus or minus a bacterial infection, but they don't have severe systemic inflammation. And if they do, that's the warning sign for you that says, bring them into the ICU. So if you have a patient that's demonstrating SIRS on top of this type of situation, that patient really needs to be brought into, and you guys all know the 4 criteria for SIRS, right? I mean, heart rate, white count, respiratory rate, and temperature. So if you have 2 out of 4, you know that these patients need to come into the ICU and they need to be managed in the ICU, in spite of the fact that initially they may not show you that much deterioration, but these can fall fast. So think about it that way. So when you're triaging these kind of patients, keep that in mind, okay? And and most common precipitating events are usually bacterial infections. And bacterial infections, remember, in these patients, the probability that you are dealing with a multi-drug resistant organism is pretty high. So you're going to have to be thinking along the lines of, okay, I'm going to have to deal with an MDR. I'm going to have to escalate a little earlier. And I'm going to have to be, if I don't escalate, let's say I go with something like a piptaz to cover the initial infection, then I'm going to have to watch closely for the next 48 to 72 hours. And if they're not getting a whole lot better, I'm going to have to jump quickly to escalate. So you have to keep that in mind, okay? And remember also, you can have, a patient that's got active alcohol abuse that's doing this, or a reactivation of or superimposition, if you will, of a viral hepatitis. So you have to think about these things in the background. But the most common by far is bacterial infection. And really, what tipped them over is the question you have to ask. And constantly thinking about what the physiology brought. I mean, what brought this on? Background. Go through your differential diagnosis and really kind of think through it. Common things are common. So you're going to have a bacterial infection. If you got a bacterial infection, is it a resistant bacterial infection? Is it resistant gram-negative? Is it resistant gram-positive? Now, one of the things I want you guys to start paying attention to in our patient populations is that we're concerned about the possibility of a resistant gram-positive as well. I know we focused in on resistant gram-negatives, but thinking about a resistant gram-positive also is very important. So you can see we have various scoring systems, the World Gastroenterology Organization, the Asian Pacific. Suffices to say that you notice that the most recent one, which is the European Association for Acute on Chronic issue, is now adding in an additional component of inflammatory issue. So when you're seeing the inflammatory, the grading is not important. What is important is that you recognize that the patient has chronic liver disease and that there is an inflammatory component on top of that. So you're going to have to deal with everything. This is a small number, I agree. But you notice in places like Davangere and other places where we're starting to see this pick up. And also you notice, here's the other thing. We kind of look at these patients and go, he's a drunk. Yeah, he's a drunk, but he's also got systemic inflammation on top of that. And now he's got this chronic liver issue plus the acute inflammation. We're going to have to take this much more seriously. And again, our survival has gotten better because our attention to detail is good. That's why in the ICU management, we've gotten better. But you notice only about half of these patients are ever discharged from the hospital. Guess what? We have to, take this a little bit more serious. Yeah, Ram Devakar, yes. You have a question? Accidental hand raise, maybe? Okay. So again, it's organ dysfunction in this case is reversible. It is not, don't think of it as, the kidneys are going out. It's usually acute kidney injury, and we'll talk about this. You can fluid resuscitate them out of this. Don't think that we can't get them out of this. The earlier we get to them, the more aggressive we can be with them, the better. So again, this is something that I want you guys to be a little bit more aggressive. Think timeline. Don't just say, okay, we'll deal with this down the road. No, deal with it now. Next slide. Okay, so again, comprehensive multidisciplinary approach, right? And systems based. So you're going to go through each system. what's the cardiovascular issues? What are the respiratory issues? What are the renal metabolic issues? So you're going to go through each and you're going to highlight them. Now, if I have acute kidney injury, by acute kidney injury, I mean, if let's say the creatinine has gone from 0.3 to 0.6, that means half of your kidney function is gone. Think about that. I mean, 0.6 is normal. Yes, it is. But if you look at the trend from going from 0.3 creatinine to 0.6 creatinine, your GFR has halved. So you really need to think about that. And you really need to pay attention to the detail as far as each organ is concerned. So that's how you want to think about it. And remember, you have to catch this patient before those reversible organ failures become irreversible. So time is of the essence. So you have to think about that. And again, you have to look for them. You cannot just say, oh, well, it shows up, the urine output will drop and then I'll address it. No, because if you address it at that time, your ability to correct that organ failure may be limited. So again, timelines are everything. So pay close attention to the detail. Next slide. Okay, so let's talk about airway, right? Remember, we see these patients, they have hepatic encephalopathy, right? And again, if they have hepatic encephalopathy, you're going to have to address their mental status, and Glasgow Coma Score documentation is extremely important. From the nursing standpoint, you guys need to get all over the bedside nurses to be documenting not just AVPU, but also GCS. Okay, remember, if I have a GCS of 15, oftentimes what I'm seeing in radar is I'm seeing a GCS of 15, but I'm seeing AVPU of P. Now, P typically can be anywhere between a GCS of 10 to about 7. So the problem is it doesn't correlate. So when that happens, what you need to be is alert and say to the bedside guys, hey, are you just cut and pasting the 15? Or is the patient really GCS 15? Or are they, do they need to be intubated is the real question. Are they 8 or below? If they're 8 or below, then you're going to have to think about controlling their airway because they cannot control their own airway. And by the way, even for a short period of time, and this is something that we looked at and we found in our ICUs, was even if the GCS drops below 8 for a short period of time, like about 4 or 5 hours, what can happen is the patient can aspirate and they can get aspiration type injury, not large volume aspiration. I'm talking small volume aspiration. And these patients 2-3 days later will develop pneumonias and stuff. Now, initially, aspiration injury, how does it present? It presents with hypoxia, okay, and to a certain degree, hypoventilation, and to a certain degree, what you will see is LV drop in filling status of the LV. Because what happened? As you aspirate, the alveoli close down, and the capillaries going to the alveoli also close down. You get increased RV impedance. And then what happens? Your LV, you get a drop in preload. So you're going to have to be thinking about this. You're going to need to be thinking about how I'm going to address it. So again, if I'm getting acute respiratory failure, okay, I need to look at those blood gases. I need to look closely. Is the patient compensating appropriately for a metabolic acidosis, or is the patient not? If the respiratory status is not compensating, that patient needs to be intubated because you don't have an endpoint. This is where NIV, while it's a nice bridge to intubation, it is not something you want to lean on for too long. Because remember, if they're aspiration risk, it's a problem, isn't it? So again, something to think about. Next slide. Now, this is just to show you how much impact the liver has. You notice it's an impact on the brain, it has impact on the lungs, it has impact on the kidneys, it has impact on infectious issues. Again, I want you guys to understand liver has huge, wide-ranging impact. In fact, so much so that when we see liver failure, remember we talk about multi-organ dysfunction syndrome, right? The multi-organ dysfunction, liver alone constitutes a multi-organ dysfunction syndrome, because the problem is liver contributes so much to so many different organs. So you have to pay attention to everything. You can't just say, oh, the patient has a little bit of liver issues. No, it's going to impact on all the others. So you need detail. So you need not just to look at the pulse ox, but you also need to look at the blood gas. You need to look at the airway issues and really pay close attention and keep close tabs on where that GCS is. Next slide. And by the way, patients with liver failure, you know how they die? They die because they herniate their brain. You get cerebral edema and they herniate and die. They don't die related to other things. They die because of cerebral herniation. So you really have to pay close attention. And this intracerebral pressures sometimes will need to be watched very closely. So you have to think about that. So again, what is the GCS? How is the brain functioning? You need a clear-cut assessment. And nursing, you guys have to get all over the bedside so that an accurate GCS is entered, so that the doctors who are looking at this patient are seeing accurate information coming back at them. You know, this is very important. The bedside may or may not recognize this, but we should. Okay, again, NIV do support oxygenation, very true. But if respiratory failure again is worsening, if you're noticing that the PaCO2 is normal and the patient has a metabolic acidosis, think about intubating the patient. You can always extubate. Be more aggressive about intubation. I know everybody and their brother says, oh, if I intubate, I may not be able to extubate. Wrong. You can extubate. We have enough expertise. I've seen you guys. Okay, you guys have enough expertise to wean and extubate patients. But if during that acute phase, if you don't intubate the patient and protect the patient, then it's going to be beyond repair. So you have to think about that. Okay, so again, think about that. The other thing you want to think about in these patients is intra-abdominal hypertension. Hypertension, that is increased intra-abdominal pressure. That is abdominal compartment syndrome. And this is where the pressure inside the abdomen increases related to the systemic inflammation that's going on. So if you go to look at the patient, just tell somebody, put a hand on the belly. And if the belly feels really tight, then ask them, okay, let's get a pressure. You can get a bladder pressure. And if the pressure exceeds 25 millimeters of mercury, you know there's a problem. Then you say, okay, we have abdominal compartment syndrome. Somebody's going to have to address that. Okay, so get your surgeons involved, get your other colleagues involved, get them to think about this. So when you're looking at lung pathology that is not getting better with your ventilatory maneuvers, think about abdominal compartment syndrome. So think about that. So these patients are susceptible for that. So you have to think about it. Next slide. The other thing that we're going to do is when we're doing lung protective strategies for ARDS, I know you guys do this on a routine basis, but you notice it's 6 to 8 milliliters per kilo, but that's ideal body weight. Please remember, if you've got a morbidly obese patient, it's ideal body weight, not actual body weight. So be careful there. It is something that oftentimes when we deal with obese patients, you're not thinking about. And a lot of these patients will be obese or morbidly obese area. So you have to think about that. So you really need to kind of keep that in the back of your mind. If you got high grade encephalopathy, earlier tracheostomy may help you, because these patients typically have a more difficult time fully waking up. So once you get them, on a vent and they're not waking up quickly, think about this as an etiology and really get them early trach so that you can control their airway. They may not need mechanical ventilation. They may just need control of their airway. So you just need to get them, trached early. So think about that. Okay. Again, you're thinking about antimicrobials for infection. You're thinking about possible diuresing or paracentesis for the ascites. So you're going to be thinking about these things. Now, when you do look at a patient with ascites, if you have a lot of fluid in the abdomen, okay, it's a mandate, and I'll go over this again when we get to the abdomen part, but it's a mandate that you sample the abdominal fluid. Even if you have a pneumonia, you sample the abdominal fluid and make sure there is no infection in the abdomen. Now, here's the other rule about infection in the abdomen. If I have one bug, here's the thing. If I have one bug, that means it can be spontaneous bacterial peritonitis. If I have more than one bug, let's say I have 2 bacteria that show up on Gram stain, there's a perforation somewhere, get that checked out. Okay, so think about that. Okay, again, and if you're dealing with pulmonary hypertension, think about, you know, medications like sildenafil to control the pulmonary hypertension. Think about that, and maybe that option needs to be left open. Again, something to keep in mind. Okay, next slide. Circulation part. Now you notice these patients will be hypotensive, but they'll be warm and perfusing. You put your hand on them and they say, they're not cold and clammy. What's wrong? Well, what's happening is total blood volume is increasing, but the circulating blood volume is decreased. So they're getting vasodilatation all over the place. So you have to think about that. And you got to think, how am I going to resuscitate this patient? And volume resuscitation is first priority. Don't just jump to a vasopressor. Give fluid. Make sure you're giving fluid. And as you're giving fluid, you can use crystalloids. But remember this, judiciously. Watch the urine output. If the urine output is above 0.5 ml per kg per hour, back off. Because every amount of salt that you provide this patient, it's going to end up in the belly. So remember that. So keep that in mind. Okay. Now, colloids, you can use. Human albumin solution can be used, and we do, but it's expensive. So you have to think about that. Again, my suggestion is, you know, think about getting the fluid resuscitation done as much as possible with crystalloid. If you need to give a little bit of colloid, the way to give it is the 25%, 50 ml, you know, quantities, and give that as opposed to the 5%. The 5% is much more expensive. You're going to run into a lot more volume, and that's the issue. So that's something to think about. And if necessary, you give them blood. Remember, the hemoglobin can be allowed to drift down to 7. Now, if you have a bleeding patient, don't track the hemoglobin, just give the blood. Okay. If you have a bleeding patient and they have, you know, you're not tracking the blood count at that point. You're just tracking the vitals and watching the bleeding. If the bleeding stops, then you can stop transfusing. But until then, and think about massive transfusion protocol. That is, you're going to give platelets, you're going to give FFP, and you may even need to give cryoprecipitate, because these patients, you're actually dealing with, you know, an issue where you're going to need to give them clotting material and everything. So you're going to need to provide that. So something to think about. Next slide. Okay. And again, the albumin concentration drops. If your albumin level is below 2, you're going to need to give human albumin. Okay. If your albumin level is above 2, it's a plus minus. Again, you can use the push-pull technique where you're giving albumin to increase the colloid on cardiac pressure, and you're giving a furosemide or something. But remember, when you give furosemide, you have to give the anti-aldosterone type of drug, okay, like the spironolactone. Otherwise, what happens is that the toxicity from the furosemide is all that's left, because in the distal convoluted tubule, the aldosterone levels being so high, everything gets sucked back into the circulation again. So you won't be able to diurese these patients with a loop diuretic alone. Remember that. So if you're giving furosemide, make sure you give an anti-aldosterone medication, whether it be triamterene, amiloride, or spironolactone. Take your pick. but you really need to think about it that way. The anti-aldosterone drugs absolutely necessary in this grouping. Okay, so again, and if they have refractory hypotension, then you need, NORAD or vasopressin. Remember this. What's your target? I see a lot of people being put on NORAD by the bedside teams. They're not watching the target. We need to watch the target. The target MAP is 65 to 70, period. You don't need an MAP of 100. Please remember that. Especially if the patient is bleeding from varices. You don't need it. What you need to do is back off, titrate it tightly, bring the MAP down to 65 to 70, keep it there. Very important. And you got to pay attention. I mean, the nurses have to titrate closely, and they have to pay close attention. We have to stay on them with regard to this, okay? And if they need an arterial line placed, get the bedside team to put an arterial, especially if they have a circulatory disturbance. Very. Next slide, please. Oh, perfect. Okay. Kidney failure. Very good. Most common extrahepatic organ failure in these patients. And guess what? It's acute kidney injury. And again, acute kidney injury, what do I have to pay attention to? Not just the total creatinine level, but the change in the creatinine from baseline. So remember that. If the creatinine doubled, your estimated GFR just went by half. So you have to think about that. You can't just say, chalta hai. No, it's not normal and it's not okay. So if I have acute kidney is predominantly in most of these patients is a pre-renal problem. It's related to hypovolemia. So you have to fluid resuscitate the patient. I mean, I know everybody talks about hepatorenal syndrome, right? Everybody loves to say that, I mean, me too, it sounds cool. But the problem is that saying that doesn't really make it true, okay? Most of it's pre-renal and most of it is hypovolemia related. So you really have to fluid resuscitate these patients. I'm not talking about just 500 ml of normal saline. I'm talking about whatever it takes to get that urine output up. Get the urine output up. Keep on it. Next slide.
Yeah, hey, I just wanted to connect the MAP point and the renal failure point just quickly. Most patients, like you said, you can start with a target of MAP of 65. That said, there will be a subset of severe hepatic injury patients where the diasts are profoundly low. That is, in fact, sometimes a defining feature. So in these patients, if you have a very low diastolic, you will not be able to attain a MAP of 65 unless you use very high doses of noradrenaline or any other agent. So typically in these patients, you can default to a subset just going to a systolic target of around 90. In these patients, your MAP may be 45 or 35, but their perfusion is typically fine because it's systolic driven. They have a natively low diastolic, and that's very common in hepatic failure patients. So
yeah,
I think
the other trick you can do is wrap their legs. If you wrap their legs, the capacitance vessels open up, right? So
correct.
One of the things that we've done in the past is, it's an old school trick, is just take the elastic bandages and wrap their legs tight. Now you have to let them loose every hour or so. But if you wrap them tight, you'll raise the diastolic pressure. There's a subset of patients that if the diastolic pressure rises when you do this, you might be able to get away without having to go as high on an NORAD.
Yes. So, and this is fairly common. So we see the titration going where they're on 2 or 3 pressors just to get the MAP high, but then the systolic goes really, really high. So you need to balance those two. So for example, in some of these patients, you'll see a systolic of 130 or 140. MAP is still 60 because their diastolic is really low. In exactly this patient, I would either do what you said, or I would just drop it to a systolic target, and that's usually enough to preserve perfusion because bulk of your perfusion is systolics driven in these patients. And that connects to the renal failure, renal protection, sort of a perfusion pressure that you need to maintain.
And they're all vasodilated, so you really don't have to worry as much about that. I mean, that's the thing that you got to keep in mind. They're really vasodilated. So that's something to keep in mind. Now, what's interesting is again, your standard renal replacement therapy indications, including, hyperkalemia, hyperammonemia, acidemia, all remain applicable. So if you feel that the patient needs to be dialyzed or sledded, I mean, again, sled is something that we use on a fairly regular basis. It's just an ultrafiltration issue. So if you want to do the ultrafiltration alone, you can do that. Oftentimes it helps these patients because a lot of times the systemic inflammatory issues are what is driving all this. So if you can clear out the systemic inflammatory issues, these patients tend to do a little better. So something to think about. But if you're going to do that, get it started early. Don't wait until the patient is crashing on 5 different pressors. So don't do that. Again, think about it that way. Next slide. Okay, hepatic encephalopathy. I know we talk about this a lot. Oftentimes, when we're looking at a hepatic encephalopathic patient, what really concerns me is stage 3 or stage 4 hepatic encephalopathy, where they start becoming somnolent, and their response to stimuli becomes very limited. Those patients you really have to worry about. Next slide. And again, remember, hepatic encephalopathy does not always correlate with the degree of ammonemia. So the fact that you have elevated ammonia level does not tell you how much hepatic encephalopathy you have. So don't use that as a surrogate, please. Okay. Again, something to keep in mind. Again, hepatic encephalopathy is a cerebral disturbance. If you're noticing mental status change, point it out to somebody. Again, but if you have normal ammonia level, this is where ammonia level is very helpful. Where you check the ammonia level, if it's normal, then they may have another reason for having the mental status change. So you have to think, is this hepatic encephalopathy or is it something else that's causing the mental status change? So checking the ammonia level, if it's normal, hepatic encephalopathy is unlikely. But that having been said, there is no correlation between higher levels of ammonia and higher degree of encephalopathy. There's never been correlated. In fact, people have looked at this and it's been studied extensively. So don't think that way. Okay. The other thing is, again, what precipitated it, and also protection of the airway, very important. Again, brain effect, you have to really watch closely, and that information has to be transmitted. Again, nursing, that information has to be transmitted to the doc managing the patient. That means the care center physician has to know. So it's very important. Accuracy is everything. So stay on that. Next slide. Okay. Here's the other changes that we're noticing. This is actually a 2022 review. So again, treatment with lactulose is okay, but again, what's your target? And again, here's the other thing that I always tell people. If you're going to use a medication, keep in mind what your target is. The fact that they're on lactulose, if they're not pooping 2 to 3 times a day, guess what? You don't have enough lactulose on board. You need to get more. Barring a patient that's obstructed, obviously. If the patient is not obstructed, you can keep giving lactulose more until you get to your target. So make sure that you get to your target. And here's the other thing. I know a lot of places love to use rifaximin, okay? Not indicated, okay? Not indicated. Please remember this. And tell your colleagues at bedside, this is not indicated in the context of acute on chronic liver failure. Now, if they're using it for something else, God bless them. I don't care. But if they're using it for this, not indicated. Next slide. Now, infection occurs in 2/3 or more of these patients. This is both a precipitant and a complication. So look for infection. Look for it, okay? And again, if you don't look for it, you're not going to find it. And again, I see oftentimes that we have central lines that are in patients for more than 72 hours. Remember, if the central line's been in for more than 72 hours, it's a possible source of infection. So you have to look at it and you have to have it changed out. I know our bedside guys are not very good at, they don't want to change it out because it's extra work for them. Get it changed. If you're suspecting sepsis in this population, boy, you're going to need to hunt down every issue. And think about pneumonia, think about urinary tract infection, and think about spontaneous bacterial peritonitis. Don't let it go. Bacterial infections dominate. Now, I know people talk about fungemias and all. Listen, small percentage, okay? So again, when you're thinking about this, think about resistant bacteria. Don't think about fungus. Don't think about viral. That's not where it's coming from. Common things are always common. It's like I used to tell people, when I take a walk in Central Park in New York, if I hear hoofbeats, it's not a zebra that escaped from the Bronx Zoo. It is a horse, and it's usually a policeman riding a horse, or it's some sort of a wagon that's being pulled by a horse. So common things are common. Keep that in mind. Trust your instincts. Your instincts in this area are usually right. And if you think it's a bacterial infection, think about resistant bacterial infection. Don't just think about, oh, it's probably garden variety. No, it's probably resistant because the population you're dealing with. Next slide. Okay, so again, if they've been on antibiotics for a long time, or if they've developed an infection late during the course of their hospitalization, or their infection, that bacterial infection is not clearing. Remember, fungi tend to tie up cell-mediated immunity. So your gram-positives and your resistant gram-negatives, both the resistant gram-positive and resistant gram-negatives, become more virulent when you're dealing with a fungal infection also in play. So if you're noticing the patient is becoming more resistant to therapy, then you got to think, do I have a concomitant fungal infection, and do I need to treat that? So again, something to think about. If the patient is on renal replacement therapy, or they have, there've been prolonged invasive ventilation, previous antibiotic use, this increases the risk for fungal infection. So you have to think about that. So again, something to keep in mind. And again, if you have severe sepsis in these patients, if they meet criteria for severe inflammatory disease, more than likely, if they don't already have infection that triggered the process, they will develop an infection. So keep an eye out. So when I'm talking about invasive ventilation, I always ask the nurses, are you noticing a change in the color of the sputum? If the sputum used to come out clear, now it's coming out tan colored, there's your pneumonia. Go for it. Look at it. Get a gram stain, send a culture, follow up, and start your empiric therapy or escalate your empiric therapy. Keep that in mind. Watch for change in how the things look as far as your patient is concerned. Keep an eye out for that. Next slide. And if you're treating with antibiotics, by the way, 3 days, things should be better. By 72 hours, things should be better. Remember, if I get a cut on my arm and I get it stitched up, right? Every day in every way, the patient should be getting better. If the patient's not getting better, you're missing something. Remember that. That's a rule for everyone to keep in mind. If the patient's not getting better, I want the nursing to say, doctor, how come the patient's not getting better? Because they should be getting better, right? If they're not getting better, there's something wrong. We're missing something. What are we missing is what you need to be questioning, okay? Okay, and again, at the point of a diagnosis, again, should be considered as having an underlying infection that's driving the progression. Okay, so again, empirical antifungal use is not indicated. And again, think about, once you have a target, let's say you found a bacteria, de-escalate your therapy. Either you need to escalate or de-escalate. By the time you get to 48 to 72 hours, you should be assessing. Diagnostic paracentesis, if you have any patient that has ascites, it's a mandate that you have it tapped. So get it tapped early. Get it tapped and just check whether there's a bacteria there or not, and get a gram stain, get a culture, you know what to do. Then just check it out. Make sure it's checked out. I know everybody loves to talk about coagulopathy. Do I have to correct coagulopathy? If the patient is not bleeding, you don't need to correct coagulopathy. If the patient is bleeding, yes. If the patient is not bleeding, the coagulopathy does not seem to be related to bleeding risk. Now, if I want to check whether the liver function will correct if I give vitamin K or not, is a different issue. Okay. If my liver function is improved, it's a prognostic issue for me. If I give vitamin K and the PT-INR corrects, then I know that the liver has reserve. If it doesn't correct, then I know the liver doesn't have reserve. I don't have to correct the PT-INR by giving coagulation issues unless the patient is bleeding. Please remember that. Okay, this is very important. Okay, they're invariably abnormal in acute and chronic liver failure. However, doesn't mean you have to correct if they're not bleeding. If they're bleeding, yes. Okay, INR correlates with disease severity, not bleeding or thrombosis risk. So again, keep that in mind. The other thing you got to keep in mind in these patients is the fibrinogen levels do drop. And if the fibrinogen level does drop, you're going to have, if they're bleeding or if they're undergoing invasive procedure, you can't just give FFP. You have to give cryo because fibrinogen levels in FFP is limited. So plasma will not have enough fibrinogen. You have to give cryo. So you have to talk to your blood bank people and let them know that you may be on to cryo. So you have to tell them this, and you have to know what you're doing as far as this is concerned. So keep the blood bank in the loop in these patients. Okay. But if they're not bleeding, don't correct. Liver transplant. If your patient is on a liver transplant, I know we've spoken about this before as far as transplant in India is challenging, yes. But if there is a transplant list that they can be on, get them on it. Because ultimately, again, if they're young, the survivability is much better with a liver transplant. So liver transplant list needs to be put on and get these people on that transplant list. Now, they may still be an alcoholic. They may be, that's up to the transplant team to decide. But as an intensivist, it's your job to refer them, and get them on that list. And once they get on the list, it's your responsibility is done. So again, something to keep in mind. Extracorporeal liver support. Now, what's interesting is there are albumin dialysis molecular systems that are available. They don't work. Okay. There has been no improvement in outcome. Okay. Now you want to talk about short-term issues. Yeah. No survival outcome. So if you want to bridge them to transplant, okay. But are you going to save lives based upon this? Probably not. Now, high volume plasma exchange has shown some improvement. Again, something to think about. Okay, if you can get your people who do dialysis, the plasma exchange, you might be able to do a plasma exchange, and those patients tend to do a little better. And if you're in serious trouble, you may be able to get them out of it. So you think about this. Okay, the plasma exchange may work. It's not just for TTP anymore. Okay, so again, plasma exchange is something to think about. Okay, so again, the future comes down to liver transplant, right? Extracorporeal liver support and immune therapies and so forth are all in the experimental phase, but it's going to come down to transplant, and transplant is really the future. So yes, we talk about all these things, but really speaking, where the rubber meets the road, we really haven't made much headway. But we have to think about the liver dysfunction and addressing liver dysfunction. Unfortunately, supportive care is the only thing we can do. And when we're talking about supportive care, I want you guys to pay close attention to all the organ systems. And that's how you're going to do this. I know I went through a lot, but I want you guys to really understand liver is the next horizon. And we're going to have to be a lot more careful. Just like kidney, we're going to have to be a lot more careful. It's not just we're going to just let it get to dialysis with kidney. We're not going to let it get to that stage with liver either. And now there are criteria now that assess the pliability of the liver, the functionality of the liver. There are testing that like Siemens is developing these testing. They're not at ground level yet. They're not quite there yet. If they were, we'd be talking about it.
Dr. Akella, mortality in DCLD, ACLF, and fulminant hepatitis, like how different would they be?
Fulminant hepatitis, remember, is no pre-existing injury to the liver. So if you can get past the fulminant hepatitis part, then you can, the probability that the patient is going to survive and have no long-term sequelae is actually really good. Remember the old story of the guy who brought fire to mankind? The guards stuck him on a mountain and exposed his liver, and an eagle would come and eat the liver every day, and the liver would regenerate during the night. The liver has tremendous regenerative capacity. So if it's just fulminant hepatitis in the absence of chronic liver disease, then it will regenerate. So this is what we see in trauma as well. In trauma, if you have a fully smashed liver, if you wait 6 months, if you can get them through the next 6 months, their liver will be completely normal. So, this is something but acute on chronic is a different beast. Yeah.
Yeah, but are there any numbers, like mortality numbers for all the three?
Again, it depends on the severity of the failure. I mean, again, if the failure is, it's all supportive care, isn't it? If I can't maintain supportive care, then the survival will be less. That's essentially it. I mean, as you get into more organs that are failing, it's the number of organs that are failing that determine survivability. So if I've got more than 3 organ failure, then the survivability is much less. If I'm getting less organ failure, yes, if I buy time, the patient will get better. So you just have to wait.
Okay.
Sharath, one thing is there's an exception that if it is fulminant hepatitis due to a toxin, most commonly paracetamol, in that case, we have decent mortality data, and there are transplant criteria on referral, and the rate of sort of recovery without transplant. There is data on that. But I think you meant non-toxin related fulminant hepatitis, right?
It's all based on organ failure, and that's essentially where we're at. So our numbers have gotten a little better because we're able to better support the organs. But again, that's the thing.
Okay.
Any other questions?
And I think one other
go ahead, Shashi.
One other fact for DCLD is when people have come with acute decompensations, the the ability of the ability for us to actually support them for the first 90 to 6 hours at least will decide whether he's going to survive or not. If we lose him within the first 24, 48 hours, then it's difficult. But once we should try to hold them tight for the next 2 or 3 days, and then they usually end up surviving.
I agree, Sashi. I mean, this is something that we've that's why timelines and aggressive supportive care and really proactive thinking. I mean, it's not reactive care that we're providing. We're actually providing proactive care because we're actually thinking about what might be happening next. And as we do that, I think the numbers get better. So I think something to keep in mind.
I just want to address Sharath's question a little bit more in another angle. See, Sharath, if you have a chronic disease, right, the acute and chronic part that Dr. Akella was talking about, what you can do is you can do your standard Child-Pugh based mortality scoring. And in that case, when they have acute decompensated liver disease based on a high Child-Pugh score or a MELD score, you can clearly tell that their 90-day mortality and 30-day mortalities are high. So it's more of a inclusion based mortality. So if they are in the fulminant bucket, they won't fit in that risk stratification. So the mortality prediction is better for the acute on chronics because we have good data sets for that. But the fulminant part, we have different diseases. So the fulminant from a viral versus the fulminant from alcohol versus from paracetamol, they have different scoring mortality predictors. So that's how I would think about it. I would say if you get the acute and chronic, use the MELD score, and then you'll get a fairly good idea like on their mortality.
Okay, for fulminant, it would be something like King's criteria or something.
Yeah, but fulminant, again, each disease has its different trajectory, right? Like they would follow different risk prediction scores. So alcohol, for example, has its own Madres index. Paracetamol has its own, and yeah, you can use the King's one if you want, but they're all different diseases actually.
Good morning. I would like to add few things, if okay. What I've noticed is those patients with come with a MELD score of less than 19 and with a CTP score of less than 9, their liver cirrhotic condition can be means to a greater extent it can be reversed. That is one thing, and mortality can be reduced. And third thing is the albumin part, if that is improved and targeted, maybe it doesn't happen overnight. It takes weeks to months together, almost 3 to 4 months. In some patients, in some few of the cases, what I've noticed is it can be reversed within a very short time, maybe 3 weeks, 4 weeks. If once the target is achieved, if they land up improving their albumin above 3.3, the mortality also comes down as well as the ascites comes down. Once the ascites comes down, the number of infection, hospitalization, and other things, the quality of life, for example, can also be improved a lot. But once they land up into CTP score above 9, or if they have anemia above like less than 8, or if they land up less than 5, and multiple transfusions and multiple paracentesis has taken place, these patients' mortality is on the higher side, recovery rate is also very poor.
Yeah,
And
unfortunately, the MELD score and all these scoring systems are not really designed for that acute on chronic issues. And that's the problem, unfortunately. I mean, because the acute process, there's all kinds of variability, and that's what we're seeing, unfortunately. It's not just decompensation, but the inflammatory processes. All right, guys, I think that concludes our academic session for today. If you have other questions, please ping me. I'm available, and we can always chat. No problem. Okay.
Thank you.
Thanks, Akella.
Thanks, guys.
Thank
Bye.
you.
Thank you, Doctor.